Okay, so today we're going to continue looking at some problems and possible solutions in the healthcare market. So last week we looked at 6 possible sources of problems in the market, starting with asymmetric information, and then looking at the incentives that the participants face, either from the consumers, the patient's perspective, in demanding as much healthcare as possible, primarily if they're cost insulated, and from the point of view of the provider, the supplier of healthcare. If the consumer is in pain, there may be an incentive to oversupply. So this is, in a sense, dictated that the market for healthcare has a role for government. There's a fairly strong rationale for a role for government. Come down a couple. There's a strong rationale for a role for government in the market for healthcare. So clearly, different countries have different ways of organising their healthcare system. Be it from an Irish perspective, we sort of have a mix between a government-run system and a private-run system, the UK system that's entirely state-controlled, or a US system that, although it's claimed is predominantly run by the market, private healthcare, does have fairly large public elements with public schemes run by the government. And one of the sort of key policy platforms of Obama was to introduce public healthcare on a much broader scale in the US. It seems like that is now set to fail, and whether he wants to bring it up or not in the upcoming US presidential election is hard to know, if he's going to revive the plans for more public care in the US. But when looking at a healthcare system, the basic challenge confronting the system is that it has a limited amount of money and a virtual unlimited way of spending it. What do you provide? To whom do you provide it? So there's basically an unlimited amount of healthcare you can provide. So the issues looking at it from either perspective, and that choices must be made. So it's no good asking patients who pay little or nothing for treatment, and will as a result demand more of everything. So we've seen examples of that over and over again in the Irish setting, where patients, particularly in regional areas, are looking at, their services to be maintained, be it in terms of local hospitals, A&E units, cancer treatment centres, whatever it might be, that there are undoubted incentives at play there. The cost they're going to face isn't going to go up. So the services are paid from general tax revenue. So if somebody takes it off you, it means the tax revenue is being spent on somebody else. You're not being asked for more. If you get the services, you're not being asked to pay more tax, and you're getting the benefit of the services. So clearly there are conflicts of interest. So in Ireland we've set up and established the Health Service Executive. So the entire system used to be under the control of the Department of Health, then with various regional health boards. And they operate on a sort of very individual basis. The services that were to be provided were provided by the Southern Health Board, the Midwestern Health Board, the Northwestern Health Board, whatever it might be, on a very regional basis. The health boards were abolished with the establishment of the HSE in 2004, and they ceased to exist from the 1st of January 2005. And a national organisation was put in place, the Health Service Executive, and it was their job essentially to run the entire health service, not on a regional basis, but on a national basis, to provide healthcare for the entire population. So the kind of structure was changed, and the HSE then was made sort of separate from the Department of Health. The Department of Health sets policy. This is what happens in a policy setting in Ireland. But the HSE is what does the operating. They're the operational sort of body who run the hospitals. They're given a certain budget, and then the Department of Health tells them, look, off you go and spend it. Try to provide healthcare in as useful a way as possible. So the HSE has to resolve this dilemma. The dilemma having a limited amount of money and an unlimited way of spending it. So who will get what type of healthcare, and who will be left fend for themselves? So we might have a huge public health budget. The HSE has a budget of about 9 billion. But even then, that is not sufficient to meet the healthcare needs of everybody. So certain choices have to be made. If you provide something for one person, you're implicitly making a decision that you can't provide it for somebody else. So sometimes these choices are fairly straightforward. So choosing between a treatment with a 20% chance of preventing a heart attack is better than a treatment with a 10% chance. So the HSC, well, what treatment are we going to provide for cardiovascular, for preventative measures in cardiovascular area? Well, we have this one that will have a 20% chance of preventing one, another one has a 10% chance. So just say, well, let's go for the one that's best. So let's not provide the one with the 10% chance. We don't have to provide that. Let's provide the one that has the 20% chance. So they make their decisions based on the effectiveness of each treatment. However, the decisions are rarely as straightforward as this. Like this is basically spending a fixed budget for cardiovascular illness. You want to get as much value for that as possible. However, how do you compare a treatment that increases the chance of walking again after an accident with a treatment that reduces the likelihood of going blind? So now somebody says you have a decision to make. You have 100 million to spend. You can spend it on a rehab centre, allowing people to have the chance to walk again, or you can spend it on providing treatment for the people who may face the possibility of going blind. And all you have is 100 million. And you must make a choice what to do. If you offer the treatment for somebody, if you help somebody to walk, somebody else is going to go blind. If you prevent somebody else from going blind, there's somebody not going to be able to walk. And these are the difficult choices that must be made with a fixed budget, with a limited budget. The fact that we don't have unlimited resources. We can't provide all things to all people. So while it seems that there's no way that you could go about making this decision, clearly the decision has to be made. Regardless of the size of the HSE budget, it is limited. So certain decisions must be made. So how can they go about doing it? So health economics and economists in general have provided some tools that are kind of useful in this sort of analysis. How do you make such decisions? And one of these tools are called QALYs, which essentially stands for Quality Adjusted Life Years. So one way of comparing treatments involves calculating QALYs of each treatment. Which treatment provides the most benefit? What is the most benefit? Well, we say it's the Quality Adjusted Life Years. If you're going to provide treatment for somebody who's going to be dead next week, you're clearly not getting some benefit from that. Okay, they're getting an extra week of life, but what is the quality of that life? If you're providing a treatment that could restore the living standards for somebody for a period of 15, 20, 25 years, there's a substantial difference there. Who is getting better value from the treatment? So a treatment that saves 10 years of life is better than one that saves 5 years of life. So that would be if the standard of living was exactly the same. If they were both going to have the same living standard, one that provides an additional 10 years of life is better than one that provides an additional 5 years of life. The issue here is that at its crudest, that's not quality adjusted. Is providing 10 years of continued life to somebody in a vegetative state the same as providing 5 years of life to somebody who's fully active? Which of those are providing better value? Somebody who's in a constant coma, or somebody who can resume a normal life? Even if it's 10 years of a constant coma, is that necessarily better than 5 years of a normal life? So the QALYs are quality adjusted for the quality of life. What sort of quality of life are you providing? So a treatment that gives someone 10 years of able-bodied life is better than one that gives someone 10 years alive but in a coma. So now you adjust for the quality of their life. So these are fierce, difficult value judgments. Like, are you going to say somebody being alive for 10 years is better than somebody else being alive for 10 years? How do you say to a family, maybe that somebody's in a vegetative state, look, there's a very little chance of this person coming out of this coma. We don't simply have the money to spend to keep this person alive for the next 10 years. Like, can you go to a family and say that? So the choices are hugely difficult. So it basically is sort of extending the choices we face in economics to a life and death situation. So this is why health is different. Like in economics, we deal with scarcity. We wouldn't have economics without scarcity. The fact that we have to choose, that we as people have to choose what to do with our limited incomes, what goods and services to buy, that we as people have to choose what to do with our limited time, what activities to engage in. well, at a health level, at a policy level, the decision is, well, what do you do with your limited budget? Who do you provide the money for? So looking at QALYs, it can sort of arise that you get certain contradictions. So if we offer treatments for being blind, that implies it's bad to be blind. Then we're looking to provide quality adjusted life years. If somebody is blind, their quality of life isn't as high if they're fully sighted. So if we provide treatments either to fix blindness or to correct blindness or to prevent blindness, we're making the implicit assumption it's bad to be blind. That QALYs are higher for people with vision. They say, where do you have a higher quality of life? If you're blind or if you have perfect vision, well, the QALYs are higher for people with vision. However, if two people arrive at an A&E department in cardiac arrest, both suffering from severe heart attacks, one blind and one not, who does the staff treat? Well, two ambulances roll up right at the very same time. The A&E department has one cardiac arrest unit. They must choose which person goes into that. So they're presented with two patients, quickly get a synopsis of their conditions, figure out that in a cardiac arrest scenario, both are quite similar, both suffering from the same severity of heart attack, but one is blind and one is not. What QALYs would suggest is that you should treat the person that is fully sighted. You should take that person who's fully sighted and put them directly into the cardiac arrest unit. Because if they survive, they have a higher quality of life. And again, this seems like a hugely a-personal decision to make. How can you choose between two patients in a life and death situation on the basis of the fact that one is blind and one is not? Both of them are alive. Why is one human life worth more than another? So if the value of life is the same for the blind and the sighted, there is no value in spending money on, say, photodynamic therapy to prevent blindness. So if in the A&E unit we decide, well, we shouldn't be choosing between these two people. These are equal. We shouldn't be choosing on the basis that one is blind and one is not. That's basically discrimination. Well, if in the A&E unit we're saying, well, there's no distinction between a sighted person and a blind person, why then when we get to the decision about money, can we say, oh, well, we should be spending money on blind people. They'd have a higher quality of life if they were sighted. So these huge contradictions emerge between how you actually go about making the decisions. And while the HSE is constantly the, I suppose, the target of attacks in Ireland, like these are the decisions that have to be made. There are huge problems with the HSE. Like the head of the HR unit in the HSE, there's about over 100,000 staff in the HSE, and the head of the HR unit has a staff of about 1,500. So he has a staff of 1,500 to run all the HR issues in the HSE. He came out and said he could run his unit with 800 people. He basically said there's 700 people extra in his unit, not necessary. So clearly if the HSE is deciding to cut healthcare services in some area, and somebody will say, well, why not cut 700 back office admin staff who aren't on the front line, who aren't distinguishing between blind people and sighted people, between those who can walk and those who face cardiac arrest with different treatments. So while the decisions on a health basis are serious and are quite difficult, there is a distinction then between sort of the admin side of the HSE, which is argued is bloated and overstaffed, and then the frontline staff. So you always get the distinction between frontline staff and what we call back office staff. But when it comes to spending money on the provision of health, these are the choices that are faced. So how do you go about organising your system? In Ireland, we're sort of stuck between the two. We sort of have a public system that has a budget of a certain amount, and we also have the private system. Like within half a mile of each other here, you have the Bond Secure Hospital. Up the road then you have Cork University Hospital. One funded entirely privately. One funded almost entirely from the state. So clearly we have a clash of different systems in Ireland. Where do you go to get your treatment? Where is the money coming from? Is it coming from the private market through insurance? Or is it coming from the public purse through taxation? Is the treatment in the bonds? Is the treatment in CUH? So the current choice is between the US insurance-based system and the UK's government-funded system. So in the US, the majority of healthcare is provided through insurance markets. So people purchase private health insurance, and if they have healthcare needs, they go to what are called their HMO, their health maintenance organisation, who provide the health insurance. In the UK, if you require healthcare, you just go to the government. The government has set up a national health service. The government has set up a system where healthcare is provided from cradle to grave, that all healthcare needs are funded by the state. GPs are public servants in the UK. They don't have private patients. You don't go to the GP in the UK and hand over £50. You just go to the GP. The GP is given a list of patients by the NHS, and that's who they take care of. So you don't swap or move, there isn't competition. And the system is one of public provision. So the Irish system is slightly between the two. We have some publicly funded healthcare provision. So all our hospitals in the public system are taxpayer funded. But then alongside those, we have private hospitals. And during the last government, there was this whole issue of co-location. That you shouldn't have a private hospital on College Road and a public hospital on Wilton Road. Put them side by side. Have co-located private and public hospitals on the one site. So further sort of integrating the two, not choosing one over the other. Not saying we're going for a private system or saying we're going for a public system. We're again trying to merge the two. In Ireland, GPs are self-employed, they're business people. They have nothing to do with the state. They set up their GP practice and patients come in and pay 50, 60, 70 euro for a consultation. They do have public patients via the medical card. So the government decides that there are some people who can't or couldn't afford to pay 50, 60, 70 euro every time they want to go and have a GP visit. So about 30% of the Irish population is covered with the medical card. They can go to the GP for free. That when it comes to the service, for them it's free, and the state then funds the GP. It used to be on a pay-per-visit basis. The GPs were paid by visit. Now it's on a capitation basis. The GPs get a certain amount of money for each public patient they have. So we're stuck between the two. And the argument is that the Irish healthcare system isn't functioning very effectively. In the midst of the boom, the health service got a lot of attention. There was lots of things working, and one of the things that wasn't working was the health system. So how do we go about improving that? Over the last 2 or 3 years, the health system has got less and less attention. So because it's not just the health service that isn't working, it's the whole economy that isn't working. So it has tended to get pushed back into the background. But Fine Gael, as part of their election platform, had, I think could have been one of the 5-point plan, I'm not quite sure, a revolutionary idea for the Irish healthcare system. They weren't so much choosing between the UK and the US. The approach they were adopting was one that was based in Holland. Social insurance. Again, it has some elements of market-based solution, it's insurance, and it has some base of public-based system, it's social. It basically means it's compulsory. That you have compulsory health insurance. So in Ireland, there's argument that we have a 2-tier health system. Those who are fully dependent on the state, and those who go and buy private health insurance. That there's a 2-tier or twin-track health system. If you're dependent on the state, you don't have to pay money, but you do have to wait. If you need to see a consultant, if you need a particular treatment, if you need an operation, you go on a public waiting list. If you're a private patient and you want to see the consultant, you might be able to see him tomorrow. If you need the operation, you can get it next Tuesday. If you need the treatment, it'll be done within a couple of weeks. So a huge difference between the access to treatment of both. One key difference between them, of course, is the funds. In the private system, the money is available immediately. Either the individual pays it out of their pocket or their insurance company provides it. Up front, bang, there's the money. In the public system, they face a limited budget. The HSE gets a fixed amount of money. It's difficult for them to predict what the healthcare needs are for the coming year. How many operations will they need? How many consultations will they need? How many treatments will they need? They can make guesses, but they can't respond quite quickly to the private system. So they have to use the resources they have in what they feel is as useful a fashion as possible. So the Fine Gael proposal was one of fair care. I think it was the fair care proposal, based on the Dutch system of social insurance, that health insurance becomes compulsory. that rather than having some people with it and some people without it, everybody has it. So how would that work if there's people who don't buy health insurance now? Are they going to be out of pocket? If about 45% of the Irish population is covered with private health insurance, 55% isn't. So what does the Fine Gael proposal mean for those 55% of people? Well, clearly there's a group of people who couldn't afford private health insurance. So now you're going to ask them to actually pay for it. And there's probably a group of people who don't want to buy private health insurance, who feel it isn't value for money for them. So what the proposal from Fine Gael is that for lower income people, the insurance will be subsidised, that the premium will actually be covered. That again, it will come from the taxpayer, but it will go to fund insurance through insurance companies. That it won't be the money going into a behemoth such as the HSC. It'll be money going into an insurance company and then what they say, following the patient. Rather than putting the money in at the top and saying, well, Jesus, what do we provide this year? That the money should come in at the bottom and respond more intuitively to the patient's needs. In the private system, the person can get what they want almost immediately because the money goes up on the counter. In the public system, you have to go and find what you need. Is the public system providing it? Is there a consultant out there to meet your particular needs? That requires the money to come down from the top to provide that consultant. In the private system, you come in at the bottom, put your money in the counter, and it's provided. So the Fine Gael system is, I'd say, on the back burner at the moment. It did have some problems at sort of the design stage, and it definitely will have problems if it ever gets to the implementation stage. When it was proposed, James Riley said they needed 2 government terms. Well, they're already a half a year to their first term, and absolutely nothing has happened. Clearly, there have been far more pressing problems for the government than trying a complete overhaul of the Irish healthcare system. So that is one proposal. Whether it'll happen or not is hard to know. But what would economics propose? What sort of system should you put in place? Given the 6 problems we introduced last Friday, is there a way we can address those and have a system that where the needs of people are met with the resources we have? But it's not just a case of resources being wasted. So we first need to pinpoint the problem and then direct the solution at the problem. So the scarcity problems in the health system are fairly easy to pinpoint. The overall problems. The first is scarcity. There's just not enough to go around. The second is that there are some externalities, particularly positive externalities, where other people benefit from your consumption of healthcare. So other people benefit from you getting a vaccination, not carrying a particular infection. And of course, as we've emphasised, there's a problem of imperfect information. Patients not knowing what's available, patients knowing what their symptoms are, and patients maybe knowing what's best for them. Then the doctors knowing how to diagnose particular symptoms, the doctors knowing what treatment is most effective, and then the doctors knowing how to maximise their own income. So we do get a sort of relationship, just like between a car purchaser and a car salesman. That there are difficulties there, but they can be overcome. In the healthcare market, the relationship between the patient and the doctor doesn't have the same checks and balances. You can lead to over or erroneous provision because the incentives are somewhat different. So government provision is ineffective because it takes decision making out of patient hands. So choosing between blind people and able-bodied people, choosing between 2 people in a cardiac arrest. When you undertake government provision, those are the decisions you have to make. Insurance suffers from market failures, so adverse selection and moral hazard. Adverse selection where only unhealthy people choose into private health insurance. Like again, the group of people in Ireland who could afford health insurance but don't purchase it. So whether you go for the government or business approach, there are problems. So the UK has gone for the government approach, the NHS has had problems, the US has gone for the market approach, and Michael Moore has clearly demonstrated some of the problems there. So if we accept that information is the key problem, well, one way is to increase the availability of information. In the public system, if you go to a consultant, you largely have to take that consultant's word. You might have been waiting 3, 4, 5 months to get in to see a consultant about a particular problem? Are you going to come out and say, look, he's after recommending this particular line of treatment, I want to go to see another consultant? Well, you go back to your own GP and say, I want to go to another consultant. When he says, I'll put you on the waiting list again, you might get in 5 months' time. The guy you go to a second time might say the exact same thing. What is the value in waiting 5 months to hear the same information again? If information is going to be useful, it must be more readily available. So getting second opinions should happen much quicker. That it shouldn't simply be a very powerful relationship with the doctor consultant having complete control over the patient. That the patient should have the ability to get second opinions. It may be necessary maybe to set up helplines where skilled, trained and informed staff can provide immediate information. Again, in most cases in healthcare, you don't actually need to be present. So most of the insurance companies have, I'd imagine, 24-hour helplines. VHI probably do, where a trained nurse at a minimum, possibly a doctor, is available. What do I do in a particular situation? You just ring up, describe the symptoms, and get back the information. This is what you should do. When you go to visit a GP, as we said before, you're not wanting him to actually do anything. You want the GP to tell you something. What should I do after here? Should I go and get a prescription? Should I go for a particular treatment? Should I undertake a particular line of help for myself? Or you could use internet sites, just have the information typed up in a very staid manner. I suppose in this issue here, you're moving down in terms of usefulness. Clearly, a personal contact where you discuss it with somebody is optimal. A non-personal contact where you discuss it over the phone is probably best. And then a very sort of staid or limited source would be internet sites. But provide the information. But the information is no good to people unless they can use it. What good is saying to people, look, there's different options out there, if it's just going to be the word of the doctor anyway? This is what you should do, or this is what you will do. So you must let the patient and not the government or an insurance company make their healthcare decisions. So there are huge problems in the market for used cars or even new cars. Yes, we let people make the choice about what car is best for them. Do people know how cars work? Very unlikely. In the healthcare system, it's about a body. Do people know how bodies work? Very unlikely. So yet when it comes to cars, we trust people to make a decision that they may know very little about with large sums of money. Yet when it comes to healthcare, we say either government, a bureaucrat must make the decision, this is the treatment we're offering, or an insurance company makes the decision, this is the treatment we're offering. We're paying for this treatment. If you're insured, we'll cover it. If you want something else, we're not covering it. If you're in the government or the public system, this is what's available. If you need something else, it may not be provided. So the solution needs to give patients choice and responsibility without putting an unbearable burden of them. One of the issues with healthcare is that the costs can run to huge levels. When it comes to cars, you're generally only going to be dealing with up to a maximum of tens of thousands. When it comes to healthcare, depending on the treatment, you could be talking hundreds of thousands, millions. So it's all very well and good to say that you want to push the burden back onto the consumers. Let's get them to make the choice. But there are cases where the healthcare costs are so large that they're an unbearable burden for someone. That no matter how much power you give them, they simply couldn't afford what they need. So we want patients to pay for many of the costs of healthcare, but the most severe costs are met by government or insurance. So very much the ongoing day-to-day, regular, frequent costs of healthcare to be paid for by the individual. But then there are large cases, maybe brain treatments, heart replacements, lung treatments, cancer treatments, long-term care, where the costs can run to hundreds of thousands. Rehab following a car accident. However, most medical bills are not catastrophic. Most medical bills are actually quite minor. A visit to a doctor, a visit to a consultant, an outpatient appointment, a stay in hospital for 1 or 2 days. It's only in the minority of cases that the actual costs balloon up. So in these cases, you don't need insurance to be there. You don't need to have insurance because the bills don't run to hundreds or even millions. So what system is proposed? So there are two elements to the proposed system. So everyone has a savings account dedicated to medical expenses, to which the government would contribute in the case of the poor or chronically ill. So at present what Fine Gael are proposing is that everybody each year would pay an insurance premium. But just like taxation, that money is pooled together. In this instance, it's pooled together in an insurance company rather than being pooled together in the HSE. And again, you're dependent on a top-down approach of the services flowing down to individuals. The proposal here is that everybody has a savings account, that you could be putting in the exact same amount of money, that instead of paying €1,500 to an insurance company, you pay €1,500 into your own savings account. And that money then is used for healthcare. If you don't use it, it accumulates. You put in €1,500 the next year, €1,500 the next year. If somebody can't pay it, just like the social insurance plan, the government steps in. So if they have insufficient income to meet that sort of minimum contribution, the government pays it. Just like the proposal that the government pays the social insurance. And just like at the moment, where the government pays for people healthcare who don't pay income tax. So if you pay income tax, you are paying for your own healthcare, although indirectly. For people who have very low incomes, they're not charged income tax, but they still get the benefit of the healthcare services. So it's not really a change of where the money is coming from. The money is still coming from the same sources. What it is a change is where the money is going. Is it being pooled together in a government agency? Is it being pooled together in an insurance company? Or is it sticking with the individual? The money following the patient. And then secondly, because collecting €1,500 per annum isn't going to be sufficient to cover your costs if you suffer from a health catastrophe, everybody is covered by catastrophe insurance, which covers large claims. So if you need serious surgery, brain surgery, a transplant, if you need long-term care, that this insurance is in place. But the issue is that this insurance only covers large claims. I'm sure that most of the claims that health insurance companies get are quite small. So the government could reduce each person's tax bill by some amount, say €1,500. So rather than collecting €1,500 in tax from each person, pooling it in the Department of Finance, and then giving $9 billion of that to the HSE, say, look, we're going to collect $9 billion in tax less this year. We're not going to give any money to the HSE. We'll reduce each person's tax bill by $1,500, and we will compulsory force them to put the money into a savings account. So you make them put the money into a savings account. It's not like that they can't use it. So in the current private healthcare system in Ireland, you can choose to purchase private health insurance. So what happens to the insurance companies is that people start to buy health insurance when they need it. They give you the $1,500 when they want far more back. In this instance, to avoid people delaying putting the $1,500, it must be compulsory. So the money goes in as soon as they start earning. And for younger people, their healthcare needs will be quite low. If you set aside €1,500 a year for healthcare, you might use some throughout the year, but you're unlikely to use the full amount. So the money would start accumulating. So for people who pay less than this in tax, the government will contribute the money to make up the shortfall, much like they do at the moment. So as the system is compulsory, no adverse selection takes place. You don't have people choosing to contribute as soon as they think they're going to have healthcare needs. You have to start contributing right from the very off. So the healthcare savings go into a bank account and earn interest. So we'll find a safe bank somewhere with a rate of return, and the healthcare savings accumulate interest. So for most people, the funds will build up gradually over time. So if you were saving €1,500 a year, what's that, €125 a month going into a savings account. Depending on what you're taking out, the funds will grow, and then the funds will start earning interest. And of course, when asked what man's greatest invention was, Albert Einstein is reported to have said compound interest. So the money starts earning interest, and then you earn interest on the interest. So the fund will start to grow. So by 40, people could have in excess of 30 grand in the account. So over 20 years, putting €1,500 in, earning interest on that, and maybe taking some money out for healthcare. And €30,000 would buy a lot of medical care. So a trips to the GP at €50-60, stays in hospital at maybe €500 or €600 a night. With 30 grand, you'd cover most healthcare needs. It would be quite a substantial sum. Any extreme expenses would then be covered by the catastrophe insurance. So if you did require a very high cost treatment, you would have the insurance policy to back that up. But the insurance policy covers very little. It only covers the high cost treatments. If you go onto the websites of the VHI and Quinn, etc., and see what's covered, they cover a huge range of things. Physiotherapy, homeopathy, alternative medicines. Really issues which shouldn't be covered by insurance because of the problem of adverse selection. But if you get people who will start using this, well, in order to cover their costs, the insurance company will drive up the premiums. And if you get more and more people using them, well, are they using them effectively? If all these treatments are available, trips to the physio, trip to the homeopath, trips to the, we will say the quack, are you going to use them in excess if you're not paying? If the insurance company is going to cover most of the cost? Just like in the public system where you're cost insulated, in the insurance system you can have the same thing then. So what happens is that for everybody else who isn't using these treatments, the cost goes up. But you want, if somebody wants to go to these physios or homeopaths or alternative medics, well, let them weigh up the costs and benefits themselves. The cost isn't that large, less than €100 in most cases. The issue is, of course, in the Irish healthcare system, is that you already have paid. You've either paid tax for the public system. I want as much as I can get. You've either paid an insurance premium in the insurance system. I want whatever the insurance company is covering. So people will use as much as they can get without weighing up the costs and benefits. So this is, in a sense, the market failure. But if somebody had 30 grand in their own account and said, look, you can go to a physio twice a week even though you don't need to. You can go to the homeopath, the alternative medic, whatever it might be, but the money is coming out of your account. You get to choose whether you have it or not. Well, now they start to weigh up the costs and benefits. So you send a person to a car showroom, pick out a car, he's paying. They'll pick the most expensive car out and drive out quite happy. Somebody goes into a car showroom and is buying their own car, they may well leave with the most expensive car, but they will only do so if they feel the costs and benefits for them are worth it. So what happens with the money that goes into these accounts? So if people reach retirement age with funds in their savings account, they can put some minimum money above some minimum into their pension. So there is the incentive to save the money. If you got to whatever the retirement age was, say 68, as it will be, then if you had a huge pot built up, a pot of money far in excess what you would spend on healthcare, well, then you can take some of that out. You've been working for 40 odd years. You've been saving this €1,500, probably index linked, for 40 odd years. You've a huge pot built up. You won't need it all. You can take some of it out. Enjoy your retirement with the money. You'll still have a minimum in the savings account, the medical savings account, to cover some needs, but you can take the rest of it out. So again, it's the incentive to save. That's not a case of, look, I have a huge pot of money saved up in my medical account. Let's blow it on an alternative medicine. Let's blow it on, what can we provide? You could purchase whatever you want with, particularly if you went to America. Cosmetic surgery, etc. Is it worth it? Well, I don't know. I have the money, I'm going to spend it. What happens when people die? If they get close to the end of life, do they just purchase and spend as much of the healthcare as possible? When people approach death or die, they can pass the savings on to other people's accounts. So a spouse, a child, a next of kin, whatever it might be. So again, there's the incentive to save. That clearly healthcare is important, that people will decide to purchase healthcare. We spend money all our lives. We don't save everything. Why should healthcare be any different? Then when we die, if we've money left up, we've an estate, it's passed on to somebody else. Why shouldn't the same happen for money that's left over for healthcare? So this gives people the incentive at all times to spend money on healthcare that they actually need. So people choose what's best for them. Just as we do across a whole range of markets. The government doesn't interfere with the purchasing decision in the vast majority of things we do. When it comes to healthcare, the role of somebody else is clearly there, whether it's the government, the insurance company, or the provider. When it comes to patients, the last person that's generally asked is the patient themselves. What do you want? It tends to be somebody else that makes the decision. So can we invert and turn that around? So some people may be encouraged to give up smoking due to the medical bills incurred. They actually see the cost coming out of their own account. However, a lung transplant would be paid for by the catastrophe insurance. So although smoking may lead to very high healthcare costs, it will still be covered by somebody else. So if they do require substantial treatment, it's not a case of saying, look, you've been smoking all your life, you've been saving €1,500 a year, you need a lung transplant, that costs 450 grand, you can't afford it. The catastrophe insurance is in place. So the system does not eliminate moral hazard. So people can still take unnecessary risks. So because the insurance is in place, somebody who smokes still has the reassurance, whatever it might be, that if they do have healthcare costs, they will be covered. However, the system reduces the problematic choices faced by a government-funded system. What treatments do we provide? So if we had a government-funded care system in Ireland, some bureaucrat would have to decide what care is provided. And we already have an example of that internationally, of the government deciding what care is provided. And that led to the LADA. So clearly we want a different system. In Ireland, nobody decides what cars are available, and the market functions quite effectively, and there's far more choice. So there's no longer a need to make decisions between patients, which patient do we treat, or between treatments. It's not a case of we have €100 million. Are we going to allow people to walk after car accidents or keep their sight? That choice isn't there. It's now at the individual's level. They have built up their saving. If they need the treatment, they put their money out on the table. And now there's a profit opportunity, and everybody can go and purchase what they wish. You don't have shortages of cars. Somebody wants to go and buy a car, it's available. We do have shortages of healthcare. So you don't have to choose between patients or between treatments. So there's no need for awful concepts such as qualities. We don't have to judge between people. We don't have to say that one person's life is worth more than another. We don't have to say that one treatment should be provided and another not. So now each patient chooses the best treatment for themselves. So there still will be exceptions, but the exceptions are only in the catastrophic cases. And these are still met by the insurance system. But what you'd find is that the insurance premium would drop and drop substantially. The insurance company isn't paying for physiotherapy or homeopathy or alternative medicines. The insurance company is only making payments in the catastrophic cases. So the number of claims would collapse by a manner, I'm not quite sure, but maybe of the order of 96, 97, 98%. What they would be left with are a small number of claims, but ones which are quite large. So the decisions which aren't made by the patient happen in a minority of cases. So there's a conflict of interest between the insurance company and the patient. The insurance company doesn't want to start spending out money on healthcare, and the patient clearly does. So the insurance company wants to provide the cheapest treatment, and the patient wants the best. However, under the proposed system, these conflicts happen less frequently, and perhaps in the most catastrophic cases, there isn't really a choice at all. You just have to provide a particular treatment, and it has to be done. Whereas in much more everyday cases, there may actually be greater choice, greater scope. And so rather than having somebody else make the decision, the emphasis is on the patient. Oops. So can we have an example of this in practice? Is this just a notion that economists can devise and say, this is what should be put into play? Well, yeah, there is one example of a country that has adopted this system. This isn't somebody just dreaming up what could or should happen. The country happens to be very similar in population size to Ireland. We have about 4.5 million people. They have about 4.7 million people. We currently have a healthcare system that's going through turmoil in terms of meeting the healthcare needs of the population, between closing hospitals, cutting down services, and providing what the patients need. In Singapore, which is the alternative, they have this system and put into place. Medical savings accounts provide a lot of the healthcare services, and the choices are made by the patient. So we'll take it up from there tomorrow, and we'll look at how this actually works in practice with the Singapore health system.